Prof. Neville Pereira for our Uromet session 5, sir. I think Manju Lehera sir will be a little late as expert today. Today's topic is penile and testicular cancers. So first we will do the penile cancer part. First speaker is Dr. S. Prasanna. He will be talk about core topics of penile cancer and penile pre-malignant lesions. Dr. Prasanna, over to you. Dr. Prasanna, are you there?
Yes.
Prasanna? Hello?
He was with us.
He's muted.
For a moment. Yes.
He's joining. Yeah.
And today our presentation is the penile cancer and testicular cancer. My topic was core topics in penile cancer and pre-malignant conditions. So it's a penile cancer. It's a rare disease, very much low in the Western countries, mainly the Europe and USA. It's less than 1% per 100,000 population. But in the Asia, Southeast Asia, and South America, those countries slightly higher. And median age at diagnosis is 68 years. So 6 decades of life, and 95% are squamous cell carcinoma. So mainly penile cancers are squamous cell cancer. So there are different subtypes are there in the squamous cell cancer. And so when we consider
Prasanna, slides are not moving.
Move the slides.
So we can see only the very first topic and your names. Okay.
So when we consider the epidemiology, so 0.4 to 0.6% of all malignant neoplasm and low incidence in the Western countries, mainly the Europe and USA, and high incidence in the Southeast Asia, Africa, and some factors. So lack of neonatal circumcision.
Yeah.
Sorry, sir. Can you see?
Yes, we can see. Continue.
Yeah, lack of neonatal circumcision, chronic inflammatory conditions like phimosis, balanitis, and male type genital lichen sclerosis, and human papilloma virus, mainly subtypes 16 and therapy, that means PUVA therapy, and STD, main factors for the penile cancer. When we consider the pre-malignant condition, mainly the pre-malignant lesion, main thing is the penile intraepithelial neoplasia, that is called PIN. In the PIN, there are different terminology: bone disease, erythroplasia of Uromet, and bonoid papillosis. These are all three included in the penile intraepithelial neoplasia. And balanitis xerotica obliterans plus cutaneous cone, and pseudoepitheliomatous keratotic and mecaceous balanitis. Those are the pre-malignant lesions. And this HPV associated, and when we consider the pathology, those penile neoplasm, mainly we can categorize into squamous cell cancer and other types. Squamous cell cancers are around 95% squamous cell carcinoma. So here there are HPV associated and HPV independent varieties are there. And other types, there are melanoma, neuroendocrine tumors, true sarcoma, and metastasis from other organs, mainly the kidney, but there are some prostate, bladder, melanoma, lymphoma. Also, they can metastasize to the penis, mainly harness tissue, and extramammary pagettes also they have reported in the penis. So, but main neoplasm in the penis is the squamous cell carcinoma. It's around 95%. Then, when we consider the squamous cell cancer, we can categorize into HPV independent type and HPV associated and other category. This, although HPV infection, human papillomavirus infection is a risk and risk factor for squamous cell cancer, but HPV associated penile cancer prognosis wise is good. The prognosis is good. So HPV independent categories are pseudohypoplastic, pseudoglandular, verrucous, cuniculatum, papillary, and sarcomatoid. And HPV associated one mainly basaloid, VT, and clear cell lymphoepithelioma like and mixed pattern. When we consider this penile intraepithelial neoplasia, so it's a type of carcinoma in situ. So here the basement membrane is intact and there's a cellular atypia in mainly the epithelial layer. So it is start from the mucous layer in the inner epithelial cells. So it can be two types: HPV, again HPV associated pin and HPV non-associated one. So this HPV non-associated usually from the chronic inflammation like balanitis or VXO, they differentiate into pin. So when the penile shaft of foreskin location, the pin is located in the foreskin, it is called as Bowen's disease. And when this intraepithelial neoplasia involve the glans penis, that is called erythroplasia of Curette. So that's the difference. But histologically, in penile intraepithelial neoplasia and the Bowen's disease, erythroplasia of Curette, and Bovenoid papillosis, all three are in the histologically same. Then squamous cell carcinoma, it can be categorized into with a grading: low grade, medium, and high grade. So when we consider the grading based on the WHO or International Society of Urological Pathology classification, there are grade 1 to grade 3, and additionally there are sarcomatoid features also with a high bad prognostic factor. Those are depend on this cytological atypia, keratinization, intercellular bridges, mitotic activity, and tumor margin. And when we consider the staging, so this TNM staging, there's a carcinoma in situ variety, and there's a TA. TA means non-invasive cancer, mainly papillary growth, mainly verrucous cancer, and T1 is tumor in the subepithelial connective tissue. Here there are grade, that means G1 or grade 1 or grade 2 tumor without lymphovascular or perineural invasion. So this T1A tumors are very minimal potential to go for the lymph node metastasis. So when we consider T1A tumor, this inguinal lymph node metastasis is very low. When this T1B is tumor with the high grade tumor, that means grade 3 tumor, or with the lymphovascular and perineural invasion, that is called as T1B. Then T2 is the tumor invade into the corpus spongiosum. So they say it can involve the glans or ventral penis. So it's invade into the corpus spongiosum with or without urethral involvement. Then T3 is a tumor invade into the corpora cavernosum. So it's a blood containing corpus tissue. So it higher grade than corpus spongiosum. So it's a category under T3. Then tumor involve the adjacent structures called as T4, mainly the scrotum, prostate, and pubic bone. Then it's considered as T4 disease. Then when we consider the lymph node staging, so mainly the clinical lymph node staging, so if the inguinal lymph node, there's no palpable lymph nodes, that is N node. And if there's a single palpable mobile inguinal lymph node, that means unilateral single lymph node, that is N1. So it should be single, palpable, and mobile. So that is N1. Then if it is more than two palpable mobile nodes, it can be unilateral or bilateral, then N2 disease. But if it is fixed lymph node or pelvic lymphadenopathy, then that is the N3 disease. So when the patient coming with the, so when we consider the penile cancer presentation, mainly the penile ulcer with the discharge and the poor odor, those things. So when we consider, so our main diagnosis is physical examination. So in the physical examination, mainly the lesion and the inguinal lymph nodes we have to examine. So in the lesion, we have to examine the diameter of the lesion, location and number of the lesion, and morphology of the lesion, whether it is papillary, nodular, ulcerating lesion or flat. Then any relationship to the other structures, mainly whether it is submucosal or spongiosum, cavernosum or urethral involvement. Then we have to examine the inguinal lymph nodes, mainly with a modified frog-leg position. We have to examine the both inguinal region and pelvic examination to identify any identifiable pelvic nodes. Then when we consider the imaging the primary tumor, the penile tumor, so physical examination is the reliable method to characterize the tumor size and clinical T stage. To differentiate between the T1 and T2, the MRI and clinical examination, there is no significant difference. But when we, for the T3 and higher up diseases, then we can go ahead with the ultrasound scan with the Doppler if there's no MRI facility. Otherwise, we can go ahead with the MRI with we can use the artificial reaction as well. The MRI sensitivity is around 80% and specificity around 96% for the differentiation of this corporal invasion. So once the imaging, then the tissue diagnosis. So usually it's a clinical diagnosis, but we can take the tissue diagnosis either punch biopsy or incisional or the excisional biopsy. For obvious large malignant lesion, usually biopsy is not mandatory, but before going for the definitive therapy, we can take a biopsy. It can be helpful for the counseling of the patients, and we can take the decision whether we can go ahead with the minor procedure or major, like partial amputation or penile amputations. So before that, then lymph node staging, as already mentioned, the lymph node metastasis is the single most prognostic factor for the deciding the survival of the patients. So mainly 5-year cancer specific surveillance is around, for the N node disease is around 95%, and like N3 disease, that means the fixed lymph nodes or pelvic lymphadenopathy, it's around 35%. So it's like identifying the lymph node stage is very important, and when early identification is very far important than the later on identification. So prognostic factors are histological subtypes, perineural invasion, lymphovascular invasion, and depth of the invasion of the, that means the T stage, and grade of the primary tumor, and the lymph node metastasis. With the lymph node metastasis, if there's any extracapsular extension, then the prognosis is bad.
Thank you, Prasanna, for a nice presentation. Finished early. Okay. Neville sir, do you have any comments on this?
Yeah, it's a kind of a comprehensive presentation. Are we discussing this anymore regarding the management when it comes to management? Are we going back to penile cancer? What is the next?
Yeah, next is management of penile cancer, sir.
Okay,
So we'll do that presentation
yeah,
and then
I think
discuss.
we'll do, then we'll go ahead with this. This is basic sort of pathological and
Yes, sir.
information. So we'll move on to the next
Okay,
presentation
thank you,
and then
sir.
we'll take, yeah.
Yeah, thank you, sir. The next presenter is Dr. Tivika. The topic is management of penile cancer. Tivika, over to you.
Good evening. Can you hear me?
Yes, we
Yeah.
can.
Yeah, I'm going to discuss about the management of penile cancer.
Presentation.
Yeah,
So,
we need to see your presentation, Tivika. We can't see anything. We can see your documents only. Did you open your presentation?
yeah, I have opened my presentation.
Okay, okay. Continue.
Okay. Shall I put it on presentation view?
Yeah.
Yeah, if you can. Thanks.
Can you see now?
Yeah, very good.
Okay. So I'm going to discuss about the management of penile cancer. So as Dr. Prasanna already he has discussed about the clinical diagnosis and the investigations and staging. So the staging wise, what we have to know is we have to know mainly about the T staging. So T staging, the T1A, we know it's an invasive malignancy. But T1B, when there's a lymphovascular invasion or perineal invasion or high grade, we call it T1B. So that difference we have to know because that is important for the management purpose. Then T2, corpus spongiosum involvement, T3, corpora cavernosum involvement, and T4, it's a locally advanced involving the scrotum, prostate, and the pubic bone. Then regarding lymph nodes also, I already mentioned N1 unilateral inguinal, and only less than 2. But N2, 2 or more than 2, or when there are bilateral inguinal lymph nodes. N3, when there are fixed inguinal lymph nodes or pelvic lymph nodes. Then I will be talking about the, initially I will be talking about the management of primary lesion, then the management of lymph nodes. So in primary management of primary lesion, again, we can classify into management of superficial non-invasive disease, management of localized disease, management of locally advanced disease. So superficial invasive, non-invasive lesions, those are the PEN and TAA. So basically that can be, so we know there's a, we can progress to invasive lesions in 2 to 13% of the patient. So we have to follow up the patient, or we can go for curative options also. Curative options can be topical treatment, surgery, laser, or surveillance. It's mainly, it's almost similar to the management of localized disease, but bit less, there are some less invasive options available. So then coming to the management of primary lesion, that is the TA, T1 and some of the T2. So basically I have got this information from the European Association of Neural AAU guidelines and NCCN guidelines. So the localized disease, in localized disease we include TA, T1 and some of the T2. So coming to the management options, so we have non-invasive as well invasive options. So they, according to some of the studies, even the non-invasive management can be compared, the outcome wise is comparable to the surgical interventions. So non-invasive management includes topical treatment with imiquimod or fluorouracil that is applied twice daily for 6 weeks. It's applied. Then we have the laser treatment. Again, laser treatment also, there are 4 types of laser treatments available, but commonly used one is the carbon dioxide. So when it comes to laser, we have to know the principle. Laser, it will not penetrate the depth, it will not go deep. So again, some limited tissue penetration is there. So when the tissue is not so aggressive, when the tumor is not so aggressive, when it is in early stage, we can do the laser treatment. Again, this laser and topical treatment also effective even after recurrent disease, even for an extensive PEN, residual PEN, even after recurrent disease, even for recurrent disease, we can go for we can go for the topical. When topical treatment fails, then we have the other option, surgical excision. So surgical actions, there are a variety of surgical options. It can differ, range from circumcision, glans resurfacing, glansectomy, white local excision, and glansectomy. So white local excision, it can be a part of even diagnostic as well as therapeutic surgery. When the lesion is small, we can go for a excisional biopsy, or it can be a treatment as well. So white local excision, earlier they said we had to have some 5 to 10 millimeter margin. Now they say even 1 to 2 millimeter margins are enough. And then, so if the tumor is in the foreskin, obviously circumcision is the treatment. And for the tumors in the glans or coronal lesions, we can go for white local excision or glans resurfacing or glansectomy. And it is suggested that with the glansectomy, circumcision also advised. And when we are considering this glansectomy, mainly the glansectomy, there are some reconstruction part as well. So we have to go for a skin grafting. It can be partial or full thickness skin grafting. So before that, we have to know whether the patient is having any risk factors for the failure of the graft application. So we have to know whether the patient is having underlying vascular malfunction, diabetes, or immunosuppression. Then the other option is, so after then finally we have the amputative surgery. Amputative surgery can be partial or total amputative. So again, we have the researchers say even for the early lesions, T8, T1, and T2 lesions, and outcome-wise, the disease-free survival and the overall survivals are similar when it comes to whether it's a penile sacrificing surgery or sparing surgery. So for the early disease, again, penile sparing surgery is recommended than the amputative surgery. So fine, but anyway, when we are deciding on treatment, we have to consider about the tumor size, histology, and the patient preference also. And I have already talked about the adequate surgical margin. So now they say even to 1 to 2 millimeter margin is adequate. And again, if the patient is having bulky disease or high-grade disease, or high-grade T2 disease, rather going for a glansectomy, partial penectomy would result in local recurrence. And other option is, for the localized disease, other option is most microscopic surgery. It's kind of plastic surgery. So until the clear margin, it is mainly to avoid unnecessarily sacrificing the penile tissue. So again, so until multiple layers are taken, until the clear margin is achieved. And it should be done in centers where it's frequently done. And fourthly, we have radiotherapy. Radiotherapy, it can be external beam radiotherapy or brachytherapy. So for T1 to T2 lesions, we can use radiotherapy. But for the lesions more than 4 centimeter with negative nodes, the radiotherapy is suggested. So if the tumor is more than 4 centimeter, or when there are palpable nodes, again, you can't go for a radiotherapy. And when you are doing radiotherapy, again, again, they suggest pre-radiotherapy circumcision. And you can also consider lymph node irradiation during the set of the radiotherapy. There are no significant disease-free survival. There's no significant difference in local recurrence or disease-free survival. There's no significant difference in the overall survival, but patients who had partial penectomy had a very good local control and 5-year disease-free survival. So when the patient is fit for surgery, better to do partial penectomy rather than radiotherapy. But if the patients who want to avoid surgical complications, they go, or when the tumor is less than 4 centimeters with the negative nodes, we can go for radiotherapy. That was about the localized disease. So I'm going to talk about the locally advanced disease. So locally advanced disease is T3 and T4. So T3 when it is involving this corpus spongiosum, T4 corpora cavernosa involvement. So again we can classify into resectable disease and non-resectable disease. For resectable disease, it can be a partial or total penectomy. So when even for T2 disease, when you are planning lancectomy, if you are not sure about the corporeal or tunica albuginea involvement, they say rather than dissecting over back fascia, we can do the dissection superficial to the tunica albuginea can be done. And so again, so it can, for resectable T3, T4 disease, it can be a partial penectomy or total penectomy. So how do you decide? Even for this, you can consider some reconstructive option. Even after partial penectomy, you can create new glands and you can consider urethral centralization with using a graft. And so when at this, the length of the surgical extent of surgical resection depends on the extent of the tumor and you have to consider the other side effects also. But if it is, so sometimes even after partial, if it is after radical penectomy, there will be problem in urinating. So you have to consider. So if the patient finds difficult, if there's a difficulty in standing up upright or with wetting the scrotum, you can consider radical amputation with diversion of the urination via the perineal ureterostomy. So what about if it is a non-resectable locally advanced disease? So non-resectable locally advanced disease, you can consider we can consider induction chemotherapy that will downstage the disease. So after the downstaging, we can go for a surgical option. If there's poor response to induction chemotherapy, again there's a place for chemoradiation. So coming to the management of lymph nodes, so lymphadenectomy can be prophylactic or therapeutic. So in the lymph node management, as we know, anatomically, the penile tissue is drained by the inguinal lymph nodes. Then the inguinal lymph nodes will be going to the pelvic lymph nodes. And they say even with the unilateral disease, there can be significant crossover to the opposite inguinal region, but crossover to the pelvic lymph node. So the drainage to the same side pelvic lymph node is common, but crossover to the opposite side pelvic lymph node is very uncommon. And when we are the examination part, as Dr. Prasanna mentioned, we had to again clinically see the extent of the disease and clinically see whether there are palpable lymph nodes, whether there are palpable superficial or deep inguinal lymph nodes. And we have to, when the disease is TB or more than TB, we have to go for a staging. So staging can be MRI pelvis and CCT. So, and when there are pelvic lymph nodes involved, it's a poor prognosis. Again, presence of pelvic lymph nodes is an indication for neoadjuvant treatment. And when there are paraaortic or paracaval lymph nodes, that is considered as a metastatic disease. And also lymph node involved, number of lymph node and the lymph node density and the extranodal extracapsular lymph node extracapsular inversion, those are the most prognostic factors. And so So it can be, there can be palpable, lymph nodes can be palpable or non-palpable. Clinically, even in non-palpable lymphadenopathy, they say about 20 up to 25 of the patient, 25% of the patients can have micrometastasis. So how do we manage the non-palpable inguinal lymph node? The non-palpable inguinal lymph node, according to EAU guidelines, they have classified the disease into, there are some prognostic classification ranging from low risk, intermediate risk, and high risk. They say low risk patients, as I mentioned before, from TB, T1A, the difference between T1A and T1B is important. So T1B, when there's a lymphovascular invasion, perineural invasion, or when there's a high grade, that is second T1B. So intermediate group is a T1B when there are these high the lymphovascular invasion, perineural invasion, and high grade lesion, high grade neoplasia present, that is intermediate group. Again, high risk group can be T2 or high disease. So the low risk patients, we can follow up the patient. We do the surveillance. For the intermediate or high risk group, we have to assess clinically, already clinically non-palpable inguinal lymph node. Then is there indication to go for imaging? So in the imaging, if there are lymph nodes, we can go for a lymphadenectomy, or we can go for so even in the imaging, if there are no lymph nodes, there are two options. We can either go for a sentinel lymph node biopsy, or we can go for a surveillance. So the dynamic regarding dynamic sentinel lymph node biopsy, it's done when there are no clinically palpable disease, and it is done as the sentinel lymph node biopsy in breast cancer. We are using the dual technique. It can be a radioisotope and the blue type patent dye and isosulfan blue. So initially we need initially the preoperatively lymphoscintigraphy also done. Then intraoperatively we are using the radioisotope technique in 99 and the blue eye technique. So and initially in the beginning the technique was associated with a low sensitivity and high false negative rate, about 40%. But there are some modifications done to improve the sensitivity. So the modification by using the by the usage of immunohistochemical staining and preoperative ultrasound scan and the FNAC. And if exploration of groins, if there are no sentinel lymph node is visualized intraoperatively. So by having this modification, we can decrease the false negative rate to about 19 to 5%. So if the sentinel lymph, this is a one method of treating the non-palpable inguinal lymph nodes. So if the sentinel lymph nodes are positive, then again we can go for a prophylactic inguinal lymphadenopathy. So if then to see whether are we going for a unilateral inguinal lymphadenectomy or bilateral inguinal lymphadenectomy, and it's also recommended that even one side is positive. Hello, can I continue?
Yeah, continue.
Yeah, so even if one side dynamic sentinel lymph node is positive, we have to go for bilateral inguinal lymphadenectomy. So that is one option is going for a delayed, one option is going for a dynamic sentinel lymph node biopsy in non-palpable disease, and the other option is surveillance and delayed inguinal lymphadenectomy. So what about the palpable inguinal lymph nodes? So palpable inguinal lymph nodes, again the palpable inguinal lymph nodes, it can be inflammatory about 30% of the patients. And there was initially it was suggested that we can try some antibiotic and then check if the initial biopsy is negative, if there are palpable inguinal lymph nodes. But again, so we had to remind that even if the palpable inguinal lymph nodes doesn't mean that it's a metastatic disease, so it can be inflammatory as well. So if there are palpable inguinal lymph nodes, we have to go for a ultrasound guided FNEC or biopsy. And if it is positive, then we have to go for a inguinal lymphadenectomy. So inguinal lymphadenectomy, there are two methods. one is the standard full template inguinal lymphadenectomy, and the other one is that is called Dassalas technique and the modified template lymphadenectomy. So this is the difference between standard and the modified groin dissection. In the standard dissection, the dissection is more extensive, and then we might have to reposition the sartorius, and we might have to sacrifice the saphenous vein, and we might have to sacrifice the fascia. But in the modified inguinal lymphadenectomy, again we are staying medial to the femoral artery, and we are not going beyond the fossa ovalis, and we are preserving the saphenous vein. Again, so the lymphadenectomy related complications such as the morbidity, because lymphadenectomy causes high morbidity. It can cause lymphedema, seroma, and the skin necrosis, and so the morbidity will be less. So modified inguinal lymphadenectomy, or we can go for a standard. And modified inguinal lymphadenectomy is suggested if it is a prophylactic lymphadenectomy. Otherwise, if it is a therapeutic lymphadenectomy, we have to go for a standard, the full template lymphadenectomy. So what about pelvic lymphadenectomy? What about the prophylactic pelvic lymphadenectomy? So when we do standard when we do the inguinal lymphadenectomy, if there are if the lymph nodes, if the inguinal lymph nodes 3 or more than 3 positive, or if there are bulky lymph nodes, or if preoperative imaging suggests there are pelvic lymph nodes, we had to go for a pelvic lymphadenectomy as well. So if there are palpable inguinal lymphadenectomy, if we feel that it's a bulky disease, and if it's fixed to the skin and the adjacent structures, and if the nodal diameter is more than 3 centimeters, there's a place for neoadjuvant chemotherapy. Because if we go for upfront surgery, we might result in high chance of skin necrosis and the wound complications. So they suggest neoadjuvant chemotherapy if it is a bulky inguinal lymph nodes, or if it is fixed to the adjacent structures. And after 46 weeks following the neoadjuvant chemotherapy, we can proceed with surgery. So again, prophylactic, as I mentioned before, prophylactic pelvic lymphadenectomy is suggested if 3 or more inguinal lymph nodes are positive, or if there are external extension in the pathological examination, or if there are pelvic lymph nodes present in the preoperative imaging. So again, the whether to go for unilateral or bilateral lymphadenectomy, So because there can be 30% of the time there can be contralateral positive lymph nodes. So again, bilateral inguinal lymphadenectomy is suggested. And in pelvic lymphadenectomy, I have already mentioned about the indications where we will go for pelvic lymphadenectomy. And again, what about is whether it's unilateral or bilateral? Usually, there's a controversial topic. The unilateral lymphadenectomy is enough. So what about clinical N3 disease? Where the lymph nodes are fixed. So clinical N3 disease, again, we can confirm with the biopsy, and it's an indication for neoadjuvant. So in summary, this is from NCCN. So when there are palpable lymph nodes, if it is resectable, we can confirm, and we can go for bilateral prophylactic. Bilateral, the same side anyway, same side therapeutic, and the contralateral side prophylactic. And if there are if the inguinal lymph nodes 3 or more than 3 positive, or if there are if there are pelvic lymph nodes in the preoperative imaging, we can go for pelvic lymphadenectomy. And if it is a more than fixed lymph node, bulky lymph nodes more than 4 centimeters, there's a place for neoadjuvant chemotherapy and surgery. So that's about the management of lymphadenectomy, the recurrence. So recurrence can be local recurrence or inguinal recurrence. So local recurrence, again, when the patient comes with recurrence, we have to restage the patient. So if we have done the organ sparing surgery, again, provided that there's no corpus for cavernosum involvement, we can go for a second organ sparing surgery. Otherwise, we have to go for partial or total penectomy, depending on the staging. And again, if we have used in the topical treatment, this time we can go for a surgical option. So inguinal recurrence, again, if the inguinal recurrence lymphadenectomy, if we hadn't performed the inguinal lymphadenectomy in the past, we can proceed with lymphadenectomy. And if we have done the lymphadenectomy before, and even if it is recurrence, well, if it is resectable, we can go for second lymphadenectomy, or we can go for radiotherapy, provided that we haven't used in the past. Or yes, we can go for chemotherapy if other options are not available, if not such possible. And they say when the patient is coming with a penile CA, what other lymph node management should be done as soon as possible, at least within 3 months. Otherwise, when they come with the recurrence, when there's a high chance of lymph node involvement, it's difficult to go for curative option. So metastatic disease, again, it's a basically systemic chemotherapy. So if there's a complete or partial response, we can go for consolidation surgery. Otherwise, we can have to go for the complete chemoradiation or the systemic treatment. Thank you.
Thank you very much, Jivika, for a nice presentation. Nevisa, do we have any comments?
Yeah, listening to Tivika is like, going through the Campbell once more.
Yes.
So actually nothing much to ask except that throw back clinical scenario to her and ask whether without the slides, whether anybody remembers this management. Okay, so are we having a clinical case scenario session, or
No, sir.
there is no separate one?
No, sir. Yeah.
Okay, last week and the first speaker. Okay, Divika, now a patient comes to you, a 60-year-old man comes to you with a reddish lesion, reddish flat lesion in the glands. How do you think you can manage this patient? How do you manage this patient? Just give us just an outline from your extensive knowledge and the description of penile carcinoma management. He comes and says that there has been, for the last 6 weeks, there has been a red lesion. It's little itchy, but not painful. How do you set about? You examine this lesion, yeah?
So my thing is a pre-malignant condition, the erythroplasia correct, and but again it can be even the early stage of the penile cancer even, and so I will see whether I will assess the extent of the disease, whether it's a multifocal disease or whether it's only in the glands. And
what else can it be? If I may stop halfway through, what else can it be? Is it always erythroplasia declarant, or what else? What are the other penile lesions which can mimic erythroplastic lesions?
Pyoderma gangrenosum and
okay. Are there any other benign conditions which can penile trauma, frictional trauma, cause penile lesions like the abrasions and things like that? Okay.
Yes.
So and even if there is a fungating lesion, are there any benign lesions which can mimic a fungating
condyloma
lesion?
acuminate.
Those are very obvious, but anything look just like a penile cancer, but not a penile cancer? Any lesion we have come across?
Luschke-Bowiski disease.
Lowen's, yeah.
Lowen's bush.
lesion. Yeah, those are inflammatory lesions. Yes. So now you see this lesion. So you are clinically diagnosing it as a erythroplasia. So how do you proceed?
So
What will you
it's
do
a
now?
so it's a pre-malignant lesion. So we
Okay, how do
can
Yeah, how do you confirm?
I
Is
will
it
take
is it a purely a clinical diagnosis?
no, we had to go for a pathological. So
How do you
I
get a
can
pathological diagnosis?
because if the lesion
Yeah,
is small, so I
how?
can go.
Yeah.
I can go for a excisional biopsy or a punch biopsy. I would prefer to go for excisional biopsy.
How do you take the excisional biopsy? Are there
So
any
I
specific guidelines of taking the excisional biopsy?
so because it's
Are
in the
you going to
glands.
take the whole lesion or part of it? Is
So
it
if it is a
incisional
small,
biopsy or excisional biopsy?
if it is a small one, I will go for a excisional biopsy and then either a primary closure or a skin grafting.
Okay. So is there any other sort of a less morbid method you can
Punch
use?
biopsy.
Yeah, that will lead a lesion which you can't close. So what is your idea about incisional biopsies of superficial lesions? Or even when it comes to fungating lesion, what is the place of incisional biopsy? Is there a place for incisional biopsy?
There's a place for incisional biopsy, sir, but we have to take the proper sample, not
What
the
is the proper
superficial.
sample? Yeah. What do you mean by
Uh,
proper sample?
With the it's like a
Yeah.
wedge resection. We with the margin, with the normal tissue and the abnormal tissue,
Yeah.
and with the margin and at least the deep, the little bit of the deep tissue also we have to take.
Yes. Yes. At the edge, from the
Edge,
edge,
yeah.
at 2 to 3 biopsies from the edge, and then like wedge, and then you can close it straight away. Okay. So now if the report comes as confirmatory of erythroplasia, what can you do?
So because
What will you do? So this is a 1 centimeter lesion. It's not healing. Now on top of that, you have given a wound also. So
because
what can you do? Yeah.
there are other topical treatment or surgical options are available because already the wound is there. The applying topical treatment or laser, it will give more side effects. So I will go for a complete excision and then skin grafting.
Okay. So you have no, you don't rely on a topical chemotherapy? What chemotherapeutic agent can you use for topical uses? It has been recommended.
Imicure or fluorouracil.
5-fluorouracil, yes,
Yeah.
creams. Yeah, okay. So suppose suppose this lesion, what other lesion can be pre-malignant? What do you know about lichen planus? Lichen planus chronicus et atrophicus. That is what we call BXO.
I think Tivika left. Prasanna can answer it. Prasanna there?
Okay, yes. Tivika left, right. Okay. Yes, Prasanna. Yeah, why not? Yes. What can you say about BXO, Prasanna? Have you come across it? Balanitis xerotica?
Yes, sir. It's a balanitis xerotica obliterans. Mainly, there's a whitish patch over the glans penis, and in the later part, it can involve the prepuce and the even distal urethra.
Yes.
And it can associate with around 5% associated with the underlying squamous cell carcinoma. So it's
right. So what will be the treatment for it? Balanitis xerotica.
Yeah, treatment mainly, sir, if it is involved the prepuce, mainly circumstance treatment. But problem if it is involved the glans penis and the distal urethra, then we can go ahead with the glans resurfacing or glansectomy, that mean wide local excision. The main problem is it can associate it with the urethral stricture. Later on, patient can develop.
Yeah. Maybe anybody else has any questions? I think I can see Moni is also there. So anybody else has any questions? Do we have time for that, or we can just
I think
move on?
we have a couple of minutes, sir.
Oh, right. Yeah.
Prasanna, what is the reason for what is the response rate for the radiotherapy? Any idea?
For the penile,
Prasanna?
no, sir. No,
Yeah,
sir.
penile cancers.
No, sir.
Okay, why do they ask for circumcision?
The mainly the poor hygiene and those are the main risk factors. So I'm not.
No, it's after radiotherapy, the prepuce can adhere firmly to the glands. That's why they're asking circumcision. Response rates are very poor, about 60, less than 60%, and the higher chance of recurrence is about up to 40%.
Yeah. After local irradiation, you can get lymphedema of the penile skin and the scrotal skin, and you can end up in a buried penis also, because it gets badly swollen, and that is a problem. That's why I think pre-radiotherapy circumcision is required. Yes, true.
Yeah. Yeah, they can get also the meatal stenosis and urethral strictures as well.
Yes.
Prasanna, what do you know about the penile cancer and the survival? 5-year survival of the penile cancer when the one lymph node is involved?
One lymph node is involved, it's around, sir, 80%. Cancer specific surveillance is around 80%. But if it is clinically without lymph nodes, sir, it's around 95%, 5 years survival.
Okay. And if it is the deep inguinal lymph node involved?
That means it's N3 disease, it's around 35%.
In N3, it is less than 10%, and N2 disease is 30%.
Prasanna, do you know the margins of inguinal lymph node dissection? Landmarks.
No, sir.
So it's superiorly the inguinal ligament, and laterally the medial border of sartorius, and medially the adductor longus. The floor is consist of pectineus muscle and iliopsoas tendon with the femoral nerve and artery and vein.
Sir, but for the modified lymph nodes, they said no need to go beyond the femoral artery.
So that is a standard
Standard.
lymph node dissection. They would ask for the margins, but the modified you can preserve the saphenous vein, and you don't need to skeletonize the artery.
Yes,
and no need of repositioning the sartorius muscles as well. Is there any other newer techniques of minimizing the side effects?
There are
endoscopic
guide.
Yeah, what type of?
Endoscopic or robotic assisted lymph node dissection, but I am not.
We can
I
put
didn't
the
read
port
that.
in the inferior pole of the femoral triangle, and it's
Yeah, that is called video endoscopic
Video
inguinal lymph node,
endoscopy.
veil or something. I think we may have a lot of questions, but we don't have much time, I think.
Yes.
So shall we move to the next topic? Testicular cancers will be moderated by Monique Clear.
Dr. Madhushanka Ekanayaka is doing the core topic of testicular cancer and assessment of the testicular masses. Madhushanka, over to you. Yes, Madhushanka, you can continue. Madhushanka, you have to unmute.
Can you see my presentation, sir?
Yes.
Then good evening to everyone. I will be discussing about the testicular carcinoma, regarding the core topics and the assessment of a testicular mass. Regarding the testicular cancer, that is the most common cancer among 15 to 40 years of age among the young population. And it is a leading cause of cancer-related morbidity and mortality among this age range. But if it is diagnosed and treated early, it has excellent prognosis. So regarding bit of epidemiology, it is more common in 15 to 14 age group. 84% of the testicular carcinomas arise from this age, and other 15% of germ cell tumors are found in age more than 40 years and above. So when come to the incidence, it's 1.5 per 100,000 population men per year. And there is predominance among the white, Caucasian and white, among the whites, with the ratio 5.4 to 0.9. Regarding the pathology and risk factors, according to the 2016 WHO classification, they have categorized the testicular carcinomas. The majority are primary testicular tumors. Among them, 95% primary tumors are germ cell tumors. And the remainder, that non-germinal, like Leydig, Sertoli, and lymphomas and other. So regarding the tumorigenic model of germ cell tumors, the initial, the precursor cells, the totipotent germ cells can give rise to normal spermatocytes, and the seminomas directly arise from the totipotent germ cells, and the totipotential germ cells can leads to embryonal carcinoma, that is the totipotential cells of the tumor cell. Among them, the extra embryonic and intraembryonic differentiation can give rise to choriocarcinoma, yolk sac tumors, and teratomas, the non-germ cell testicular tumors. Regarding the classification, the WHO 2016 histological classification of the germ cell tumors, the seminomas, 35 to 40% of the total testicular tumors. And other the non-seminomatous germ cell tumors group, the yolk sac tumors, teratomas, the embryonal carcinomas, choriocarcinomas, and mixed cells tumors. Non-germinal cell tumors are the specialized gonadal stromal tumors, such as Leydig cell tumors, Sertoli cell tumors, and gonadoblastomas, and other variants such as carcinoids, adrenal rest tumors, and mesenchymal tumors. Regarding the seminoma, these are the 85% are pure or classic seminomas without any specific tumor markers. Here, LDH can be used as a tumor bulk assessment and the treatment response. Among them, 15% have some syncytial trophoblastic component with some beta-HCG secretion. But the higher alpha-fetoprotein level can exclude the diagnosis of seminoma. Regarding the less aggressive, the seminomas are less aggressive than non-seminomatous germ cell tumors. Among them, 2/3 are patients present in the stage 1 disease. And here's the special feature is, hello? Here, special feature is that there is no poor risk category in the IGCC classification because of the tumor, depends on the with the tumor marker levels, mediastinal and non-pulmonary visceral mets, and it's highly radio and chemosensitive tumor. Even with the lymph nodes up to 5 centimeter, with the radiotherapy they can cure. And the stage 4 disease, they are highly sensitive for the chemosensitive chemotherapy. And seminomas, there are special types such as anaplastic tumors. 10% of the seminomas account for that, and 30% deaths due to anaplastic seminomas. They have higher mitotic activity, faster spread, and present in the advanced stage. And other varieties, the spermatocytic seminoma, they are around 1 to 2% of seminomas and present in elderly males. And it has best prognosis and no metastasis usually, and with the radical logidectomy, it can cure. Regarding the non-seminomatous germ cell tumors, a group of various histologies such as usually mixed cell tumor, yolk sac, and teratomas. And the yolk sac tumor is the most common testicular tumor in children, and the teratoma is the most common testicular tumor in the second most common testicular tumor in the children. Younger age of presentation than the seminomas, usually by 5 years, and it's more aggressive than seminomas. 2/3% with the nodal or higher disease, and it's highly chemosensitive, but no role in radiotherapy. Regarding the other tumors, such as Leydig tumors, is 1% of the total and 10% malignant, present with the gynecomastia and the cytoplasmic inclusion called renic crystals, and it's never malignant in prepubertal boys. And it's only malignant when the metastasis is seen. And regarding the Sertoli cells, is less than 1% and 10% is malignancy. The malignancy is only diagnosed by the metastasis. Regarding the risk factors of testicular carcinoma, the testicular maldescent is a known risk factor, and there is 5 to 10% fall risk of associated risk. And if there is a prior history of cryptorchidism, there is a 10% risk, and higher in the bilateral disease. And even if the normal contralateral side, there is a 20% increased risk to the normal contralateral side. And it's associated with the testicular dysgenesis syndrome, because there are controversies that the testicular maldescent and the cryptorchidism and the testicular tumors are it's not a it's a association, and the hypospadias is also associated with the testicular carcinomas, and contralateral tumor associated the 25-fold risk of testicular malignancies, and the incidence of younger age has high risk of metachronous seminomas in the other side. So regarding the perinatal risk factors, low birth weight and the low gestation age, maternal age, and the smoking, parity, and birth order is also, they have those are not a very convincing evidence. The heterogeneous evidence are there with those factors. And the postnatal risk factors, high fat intake, dairy products, also there are heterogeneous evidence. And HIV and the other cytomegalovirus, EBV, also implicated in the etiology as well. Regarding the genetic factors, it's suggestive of a shared gene hypothesis and 8-fold risk in first-degree relatives. Also, the Klinefelter's Down syndromes are associated with the germ cell tumors. Regarding the clinical presentation and the diagnosis, the local disease can present with the painless testicular masses. Around 20% may present with the scrotal pain and features of orchitis, and some may present with the gynecomastia, especially in Leydig cell tumors, and recent onset lax hydrocele can present with the localized disease. And the metastatic symptoms are retroperitoneal masses, neurological symptoms, back pain, pulmonary symptoms. They can present with metastasis. Regarding summary of the diagnostic procedure, the lab findings, mainly the tumor markers, I will be discussed here, and the imaging and the other supportive investigations such as fertility investigations. Tumor markers, they are implicated in the diagnosis, staging, risk assessment, and the evaluation of the response. When it comes to the tumor markers, HCDs, they comes from the syncytial trophoblast cells and elevated in the choriocarcinomas, 50% embryonal carcinomas, and 5 to 10% of pure seminomas. And usually the levels less than 1, and it has half-life of 24 hours. The beta subunit has 1 hour of half-life. Then the alpha fetoprotein, they are secreted by the yolk sac, and its presence rule out the pure seminoma and the pure choriocarcinoma. It has a half-life of 5 to 7 days. And regarding the LDH, there are many isomeric types, and it is a marker of bulk of the disease. And it used to monitor the advanced seminomas, and it's negative in non-seminomatous germ cell tumors. And regarding the imaging, ultrasound has a high sensitivity with the high frequency ultrasounds, but it may be operator dependent. CT abdomen pelvis test used in the staging, when it comes to ultrasound and the CT, MRI has no added benefit, and the PET is not useful in the initial setup, and it is useful in metastatic disease. And the fertility assessment, especially the hormone levels and the seminal fluid analysis, it's a supportive investigation. Regarding the ultrasound, 1 to 2 millimeter size intratesticular lesions can be detected. And the seminomas may present with hypoechoic lesions without cystic areas. Non-seminomatous germ cell tumors are inhomogeneous with calcification and cystic and indistinct margins. But tunica is difficult to discern, so a local staging is unreliable with the ultrasound scan. And it can detect microlithiasis. Microlithiasis are 5 or more echogenic 1 to 2 millimeter size foci of calcification. Those are considered to be associated with testicular carcinomas, but there are controversial ideas in current literature. So regarding the CT, it's useful in the staging and the PET CT has limited value in the primary disease, and the CT can be useful in the post-therapy. The PET CT can be useful in the post-therapy residual disease. This is regarding the AJCC TNM classification. I won't be discussed here because of my colleagues will discuss in next presentations. Regarding the stages, it's again a bit about the IGCSE prognostic groups. There are 3 prognostic groups, depends on the tumor size and the tumor marker levels and the non-pulmonary and pulmonary visceral metastasis. The special feature here is the seminoma has no poor prognosis category because of it's usually it has better prognosis when compared to non-seminomatous germ cell tumors. A bit about the testicular biopsy, it will be useful in when the precise clinical diagnosis is impossible, and if there is suspicious lesion and the patients with to rule out the germ cell neoplasia in situ, patients with high risk features with usually the patient who are having low volume testis, cryptorchidism patients, and the patient with poor spermatogenesis. And radical inguinal lobectomy is usually diagnostic of testicular carcinoma. That's all regarding my presentation, sir. Thank you.
Thank you, Madhushan. Before moving into next, are we going to discuss Neville, sir?
Yeah, what are the other topics now we are going to discuss?
Management of seminomatous germ cell tumors and the non-seminomatous germ cell tumors are the next 2 topics.
Right. So can I ask some questions from the speaker? I asked you a good presentation, and how do you do the biopsy? Now, suppose there is a suspicious lesion in the ultrasound, let us say about 3 centimeter lesion, and generally they present with some sort of a history of local trauma, but then there is no pain. But they say that following the local trauma, they just come for a routine ultrasound by the general practitioner, and they find a hypoechoic lesion. So, so how do you confirm whether it is a testicular tumor or not?
Apart from my history examination and the imaging findings, I can go for the inguinal testicular biopsy, sir.
Okay. So, do you have any idea about the technical details of it? Now, this is ultrasonically detected tumor and may not be palpable. What can you do? What is Shevasu's maneuver? Have you heard about it? Shevasu's maneuver. Yeah, you're right. You're halfway through.
I have heard of, sir. I can't remember.
Yeah, that's exactly what we're trying to say. That is inguinal exploration, and if having real suspicion, you keep the pathology lab ready for either imprint biopsy or for frozen section, and then you go ahead with this procedure. And sometimes this might be asked at the vivas. And then you dissect it up to the deep ring and then clamp it, temporarily clamp it. And you can, if you have some idea where exactly it is, you make a polar incision, vertical incision, and then you open it and take a biopsy and then close it. So you can close the tumor. So that is the only way you can be 100% sure that you have taken a good sample. It's called Shevasu's maneuver. And any other views about it, Nishanta and Muni? Can add? Biopsying the testes? Yeah.
Nothing, sir.
Yeah. Okay, so just know about it. And that is one question. And then suppose it comes negative, you can keep the patient under surveillance. But if it is positive, you just start managing the tumor.
Madhushan,
Yes, sir.
can you just go to your presentation and show the alpha fetoprotein regarding the alpha fetoprotein, that slide?
Okay.
Right. So you have mentioned the PO choriocarcinoma and PO seminoma is secreting alpha fetoprotein. No, not.
No, sir, it's rules. The presence of alpha beta protein, they rules out the pure seminoma and the pure
Right. Right. Okay. I want to
Because-
clarify that. Yeah.
Yeah,
Okay.
it is because alpha beta protein is secreted by yolk sac elements. So
Yes.
those are not there in pure seminomas.
Yes.
Right. Biopsying is one, and yeah. You said something about staging, isn't it? So now suppose you come across this incidental tumor. The next speaker is going to talk about staging, or you can tell me how you are going to stage this tumor?
So usually we thought we will discuss in the core topics, no? The staging should discuss in the core topic rather than the management part.
Yeah, so the next speaker will be the last speaker, isn't it?
No,
Yeah.
sir.
Two
Two
more.
more. Yeah,
Two
we'll
more.
go ahead with that then. Huh?
Right. So shall we move into next?
Yeah.
So next speaker is Dr. Mahendra Herath. He will discuss about the management of seminomatous germ cell tumors. Over to you, Mahendra.
Can you see my presentation?
Yep.
Today I'm going to discuss about the management of seminomatous germ cell testicular tumors. The primary treatment is inguinal orchidectomy because it is the standard treatment for patient who is having germ cell testicular cancers, as pathological studies shows multifocal as well as adjacent germ cell neoplasia, about 20 to 30% of the patient with germ cell tumor. And usually scrotal approach should be avoided when testicular cancer is suspected, as it is associated with higher local recurrences. And there is a place for testicular sparing surgery as well in patient who is having synchronous bilateral tumors or testicular tumor in solitary testis. In this testicular sparing surgery, at least 2 additional testicular biopsies should be taken to exclude germ cell neoplasia in situ. And if we are doing testicular sparing surgery, portion section should be also done. And when we do the testicular sparing surgery, patient should be informed about the local recurrence rate, which is about up to 26%, as well as impact of radiotherapy if germ cell neoplasia is present. Because if we given radiotherapy, they will have potential. They have potential to develop infertility, as well as they need hormonal replacement therapy despite preservation of the parenchyma, as well as there is discordance between the frozen sexual examination as well as the final histology requiring delayed orchidectomy in this kind of patients. Then germ cell neoplasia in situ. The 5-year risk of developing testicular cancer is about 50%. So if contralateral testis is normal, available options are the orchidectomy or close observation for patient who is in germinal cell carcinoma in situ. If solitary testis is there, local radiotherapy should be considered. But if local radiotherapy given in the solitary testis, they can result in infertility, as well as they can develop Leydig cell insufficiency. So if patient is wishing for any fathering, we can defer the radiotherapy with the regular monitoring. Then management after orchidectomy, that is depend on the clinical stage of the disease. First, clinical stage 1, up to about 20% patient who is in clinical stage 1 disease have up to 20% subclinical metastatic disease, usually in the retroperitoneum, and they will relapse after orchidectomy alone. And the risk of relapse is in 5 years 12 to 20%, and most occur during the first 2 years of the treatment. And less than 3 centimeter size as a single parameter, the risk of relapse is 12%. And regardless of the management, survival on stage 1 disease should be almost 100%. And the risk stratification in germ cell cancer, tumor more than 4 centimeter and stromal retrotastic invasion may stratify patient into low and high risk groups, with both small, that is less than 4 centimeter, and the absence of stromal retrotastic invasion is recurrence is less than 6%. The available option for management of clinical stage 1 is surveillance, adjuvant chemotherapy, adjuvant radiotherapy. In the surveillance, it needs strict protocol of repeated imaging, monitoring of tumor markers, as well as clinical assessment. Cancer-specific survival rate of active surveillance for clinical stage 1 is over 99%, and it is cost-effective compared to the other option. But because of repeated imaging and repeated clinical examination, it may be burned to the patient. Then adjuvant chemotherapy. RCT has compared 1 cycle of carboplatin with adjuvant RT, which shows no difference in relapse-free rates, time to recurrence, as well as survival after median follow-up for 4 years. Adjuvant carboplatin is alternative to radiotherapy or surveillance in clinical stage 1 seminoma. And when we come to relapse, time to relapse after carboplatin may be longer than with the active surveillance. And most patients relapsing after carboplatin treatment can be successfully treated with a standard stage-based cisplatin-based therapy. Adjuvant radiotherapy. There is a long-term risk of developing non-germ cell malignancies in radiation field. So this is generally reserved for highly selected group of patients who are unsuitable for systemic therapy. The EUA recommendation for management of clinical stage 1 disease. This is summary of my previous slides. Then clinical stage 1 disease with persisting elevated tumor markers after orchidectomy. If tumor markers fail to normalize after orchidectomy, ultrasound should be done to exclude contralateral testicular cancer. And if tumor is excluded, repeat staging should be done after 4 weeks. And if small elevation of tumor markers is there, we can monitor these patients initially. And treatment should be commenced if markers rise or when follow-up imaging demonstrates metastasis. Metastatic disease, clinical stage 2A and B, patient with enlarged retroperitoneal lymph node which is less than 2 centimeters with normal markers. Normal tumor markers may be observed for about 6 to 8 weeks with repeat imaging, as these may be non-metastatic. In such case, treatment should be only initiated metastatic unequal based on biopsy, increase in nodal size, and number of increase of markers. There are no randomized control trials comparing radiotherapy and chemotherapy, but there is a meta-analysis of 13 high-quality studies comparing efficacy and toxicity of radiotherapy and chemotherapy. So, similar effectiveness with both stage 2A-B, with non-significant trend toward greater efficacy for chemotherapy in stage 2B disease. And standard historical treatment has been radiotherapy, reported death rate of 9 to 23%. Radiation field includes parotid and equilateral iliac nodes, but radiotherapy has long-term side effects such as bowel toxicity and secondary cancers in irradiation field. Chemotherapy with cisplatin, etoposide, or bleomycin is the option. So currently, clinical stage 2A and 2B, the standard treatment is chemotherapy, but radiotherapy is reserved for patients who is elderly, have contraindication or difficulty tolerating systemic chemotherapy.
Mahendra, what is that noise? Is it your fan switch on or?
Don't
Dr.
know.
Sirivardhana, your phone is unmute, please.
Now
Yeah, now it's better.
primary retroperitoneal lymph node dissection. It has been reported in clinical stage 2 disease, but there are no solid evidence for primary retroperitoneal lymph node dissection for clinical stage 2 disease. Then this is the overall management of clinical stage 2A and 2B disease. The metastatic disease is stage 2C and stage C, and cisplatin-based treatment should be used, and cisplatin-based combination treatment has shown superior efficacy over cisplatin-based regimes, and there are good prognostic seminoma which need 21-day cycles of BEP EP if bleomycin is contraindicated, and there are intermediate prognostic group seminoma that these patients need treat with BEP for 4-cycle standard treatment. And if bleomycin is contraindication, etoposide, cisplatin, or ifosfamide regime should be given. And the residual tumor resection, the residual mass of seminoma should initially be monitored with imaging and markers, as inflammation and desmoplastic reaction induced by chemotherapy may result in false positive result with imaging. So, as there is a high negative predictive value with PET-CT, if the residual mass is more than centimeter, we should consider the PET-CT. And PET-CT should not be done until after 2 months after completion of chemotherapy. If volume is same in PET-CT, we can repeat the PET-CT in about another 6 weeks time. And if volume is increasing, salvage treatment is indicated. And patient is persistently high or progressing beta HCG after first line chemotherapy needs salvage chemotherapy. And progressing patient without beta HCG progression need histological verification is percutaneous or surgical biopsy before salvage chemotherapy. When retroperitoneal lymph node dissection is indicated, this should be performed in high volume centers only. Thank you very much.
Thank you, Mahendra. We will move to next topic as well. Then we will discuss. Is it okay, sir?
Yeah, sure. I think we can sort of decide what we are going to ask, like, no? Yeah.
Yes, sir. Right. Next speaker is Dr. Chaminda Alahakon. He will discuss about the management of non-seminomatous germ cell tumors. Chaminda, over to you. You can start, Chaminda.
Uh, Good evening, everybody. Today, I am Chamin Dalhakun, Senior Registrar from CMPH Ragama. Today, my topic is to discuss about the management of non-seminomatous germ cell tumors. When comparing with the seminomatous germ cell tumors, which as Dr. Madhusanka mentioned, the seminomas usually arising from these more differentiated primordial germ cells, and these non-seminomatous germ cell tumors originate from the undifferentiated embryonal germ cell. So, along the progression of this cancer, they can differentiate to any cell lineage and give it rise a lot of histological subtypes. And when considering the management of non-seminomatous germ cell, apart from that, this mixed germ cell tumors also are categorized under this category to the purpose of the management. And so usually diagnosis is achieved by this primary orchidectomy, but before that, histological diagnosis with elevated alpha proteins and beta HCG might suggest the diagnosis of this non-seminomatous germ cell tumor. So, as my previous speakers mentioned about the staging, but most important thing is this overall stage of the disease, which will help guide us for our management. So here, usually this T1 usually demonstrate that this tumor more confined to the testis, and stage 2 is which shows that the tumor with this lymph node involvement, and the stage 3 disease basically for the metastatic disease, which will guide the other treatment in the future. And apart from this tumor stage, this intentional germ cell cancer collaborative growth classification, prognostic classification also very helpful in the deciding of the management option. This classification usually based on primary site, histological subtype, and as well as tumor markers and the distant spread. So the highest one will belong to the category. So usually when consider this non-seminoma, which will prognostic classification, it will give us a good prognosis, intermediate and poor prognosis, depending on that. So usually this nodal or lung metastasis comes at the good and intermediate prognosis group, but visceral metastasis goes for the poor prognosis category. When it comes to this treatment for this advanced disease, in the about 50 years ago, this advanced testicular cancer, most of the advanced testicular cancer result with the death, even with this large field radiotherapy. But in the 1970s, they introduced this systemic chemotherapy, initially with this PEB regime, that is cisplatin, vinblastine, and bleomycin regime, which shows there's an improved about 35% complete response rate. And in the later, around 1980s, they introduced this BEP regime, which is the gold standard at the moment, and with less side effect profile than this PEB regime. And after that, there are so many regimes emerging throughout this period, but they are having increased toxicity without any comparable outcome benefit. When we consider this starting the chemotherapy, the optimization prior to the chemotherapy is very much important, because these testicular tumors are very solid tumors, and also they are very chemo sensitive. And so due to those reasons, they will commonly give us this tumor lysis syndrome, which will result in either hyperkalemia and arrhythmia formation, and also this acute kidney injury, and as well as hypocalcemia. So early identification of this risk patient, as well as the rehabilitation with the combination with the physician, would be really necessary before starting on the chemotherapy for those kind of patients. And apart from that, those tumors usually they are having this retroperitoneal lymph node mass involvement, and with this inferior vena cava involvement is very high, and this vena caval tumor thrombus also might be there. With this induction, with the start of the chemotherapy, there will be a rapid tumor shrinkage, and shrinking of the tumor will result in the embolization, will lead to pulmonary embolism and death. So in that case, we have to think about the anticoagulation prior to the chemotherapy, but we have to think about the bleeding risk as well, especially when there is a cerebral metastasis. There will be a high risk of cerebral hemorrhage, and as well as if there are choriocarcinoma subtype, there will be an increased bleeding risk. In that case, we have to weigh the benefit and the risk and decide on anticoagulation. But if there are any high risk of bleeding, in that case, we can consider the IVC filter, and apart from that, pre-chemotherapy ureteric stenting and lung function assessment also very important. Then going to see the management. So usually we discuss the management basically divided into two groups, that is stage 1 and the disease beyond the stage 1. So the clinical stage 1 disease means that the tumor is confined to the testis, and again it can be divided into this treatment can be divided into the risk stratification into low risk and high risk, that is tumor without lymphovascular invasion and tumor with the lymphovascular invasion. So usually there are management options include this surveillance, adjuvant chemotherapy, and the retroperitoneal lymph node dissection. So when you take the surveillance for the whole group, including this lymphovascular invasion, so there will be a risk of about 50% of relapse. And this is this risk stratification method. And so even EUA mentioned about this relapse rate with active surveillance is up to 50%. So the surveillance usually done with the repeated cross-sectional imaging, monitoring of serum tumor markers, and the clinical assessment. So, but when it comes to this high risk disease, that is lymphovascular invasion present, so the adjuvant chemotherapy will have the more benefit than the active surveillance, and usually the one cycle of BEP regime would be enough. And usually in the clinical stage 1 with this presence of chemotherapy, the retroperitoneal lymph node dissection usually doesn't have a pace, but if there are a patient with a teratoma with somatic malignant component, which might be a chemo-resistant tumor, that is an indication for retroperitoneal lymph node dissection, as well as the patient is unfit or a patient will. And so there are some. This is one trial which is a AUO trial which has compared this outcome from this adjuvant chemotherapy versus radical retroperitoneal lymph node dissection. It shows that results are favored for chemotherapy with recurrence-free survival with no clinically relevant difference in quality of life. So as a summary, in the clinical stage 1 group with low risk disease, the standard management should be the surveillance. With high risk vascular invasion, if the vascular invasion present, so the standard treatment would be the adjuvant chemotherapy with one cycle BEP regime. So, but all the other options are also included in this management. That is, we can take the decision with the discussion with the patient as well. When moving to the management of advanced germ cell tumors, so apart from this stage 1 disease, we have to think about the stage 1 disease with elevated serum tumor marker, that is called as stage 1S. So in that case, we have to know whether it is this persistently elevated tumor markers either due to the contralateral metaconus tumor or a subclinical metastatic disease. So in that case, it's a contralateral testis ultrasound examination is a must thing, and after excluding that, we have to think about the subclinical metastatic disease. So the management again as a metastatic disease according to this risk prognostic classification. When moving to the treatment option in the patient clinical stage 2A disease, that is this tumor with lymph node involvement, which less than 2 centimeter size lymph node. So the management will mainly differ according to the positivity of tumor markers. So that tumor with this low bulky lymph nodes associated with the positive tumor markers. So in that case, we can again this is stratified according to the IGCCG risk groups. and according to that we can follow the chemotherapy regime. And after that, usually in this non-seminal germ cell tumors, we have to repeat the imaging about 4 to 6 weeks if there's a residual tumor. So then in that case, we have to go for a retroperitoneal lymph node dissection, because that is a surgical option. That is for the tumor marker positive arm. When considered tumor marker negative one, so either we can follow up with the imaging or go for a radical retroperitoneal lymph node dissection and follow accordingly. When moving to this metastatic disease, here we include this metastatic disease per se and stage 2C disease, which is a very bulky lymph node having a very high risk of metastasis. So those two categories again we manage according to this prognostic classification. So the standard treatment would be this BET chemotherapy regime. So usually this interval with 21 days, and the cycles will depend on the prognostic group. So usually with this good prognostic group, BET regime of 3 cycles would be enough, and from beyond that, that is intermediate or the poor group, there will be a additional of another 1 BET regime is indicated. So if there are any contraindications, so we can go up to this VIP regime, which has more serious side effects. After the chemotherapy, about 4 to 6 weeks, then we will go for this reassessment with the radiotherapy. There we will classify the disease according to the radiological assessment. Either it is complete response or persistent radiographic tumor with normal tumor markers or positive tumor markers or disease progression. If there is residual tumor, so after this initial chemotherapy management, so up to date, this recent data shows that about 6 to 10% of those residual masses can contain active cancer, and about 50% there will be this post-pubertal teratoma, and 40% about necrotic fibrotic tissue only. When compared with the seminoma, in the non-seminated germ cell tumors, there is no place for this flow glucose PET scan, and instead we have to go for we have to think about the surgical resection if it is a residual mass is more than 1 centimeter. When considering the retroperitoneal lymph node dissection, it should be done by an experienced surgeon in this high volume center, and we can go ahead with this nerve sparing technique, but still it has a very high it has a risk of retrodegeneration around 6 to 8%. Surgical approach wise, it can be open, laparoscopic, or robotic assisted. When considering this lymphatic drainage of this testicular tumors, usually these non-seminated germ cell tumors grow along the limb, except for this choriocarcinoma, which goes with the hematogenous spread. So they usually tend to go on ipsilateral direction. So usually in the general anatomy of the lymphatics, left there is drainage from right side to left side. So usually right side testicular tumor can give rise both involve the both para-aortic and as well as the cerebrocardial lymph nodes as well. So usual recommendation is the bilateral nerve sparing retroperitoneal lymph node dissection, but in this some particular questions we can consider ipsilateral template resection, usually in the left side tumors. And when considering the laparotomy, if we plan for both abdominal and lung mass resection, we can combine with thoraco laparotomy if possible, and otherwise with the conventional laparotomy. When considering the resection of lesions in the other organs, so the current recommendation is where appropriate and feasible resection of residual lung and brain lesion. When consider the brain lesion, if there are any definite indications for resection, if it is a chemo-resistant or any persistent solitary mets despite of this chemotherapy, in that case we can consider the resection of other lesions as well after discuss with the multidisciplinary team. And when consider this is relapse, so usually the median time for the relapse is in non-segmental germ cell tumor is 7 months, but majority of those relapses seen within first 2 years. That is very important to make our follow-up plan. And usually late relapses after 2 years also there, and however there are rare instances which have reported up to relapses up to 24 years after the initial definitive therapy as well. So relapse disease, then we have to think about some alternative chemotherapeutic agents. Those are again cisplatin combinations, and this survival benefits, there are no RCTs up to date about comparing those treatment regimes. When consider following up, the idea of following up to identify this early identification of the tumor recurrence and as well as to detect the treatment-related toxicity as we described earlier. And follow up to identify this tumor recurrence, the following up plan, we usually have in this intense follow-up plan during the first 2 years with this tumor markers, chest X-ray and CT and CT or MRI imaging of the abdomen and pelvis with the CT chest, and then less frequent in from 3 to 5 years, and thereafter it is individual based management follow-up plan. Little bit about primary extracondylar non-seminimatous germ cell tumors. Those usually commonly arising from the mediastinum and as well as retroperitoneum, and especially in the penile gland in the brain. So the pathogenesis of these extracondylar germ cell tumors are not clearly identified, but there are some theories they might develop from these primary germ cells that fail to normally migrate along the genital ridge, or they develop from the germ cells in the testes and undergo reverse migration. Those are some theories regarding the primary extracondylar tumors. So mediastinal tumors, their symptoms may be due to this related to the respiratory system, and also they are having high HCG, which might cause gynecomastia. And initial diagnosis usually can be done with this chest X-ray and CT, and definitive diagnosis is by the histology. And treatment also based on the pathology, and they're having somewhat poor prognosis, and treatment would be initial chemotherapy and followed by the surgery. Primary retroperitoneal tumors as also they might present with the symptoms due to this retroperitoneal mass effect, and treatment again with the chemotherapy, and if there are any residual, we have to go for a surgery. So with this, I will wind up my presentation, and thank you.
Thank you very much, Chaminda. Your nice presentation and deep explanation of the management. And we will move to discussion. Sir.
Yeah, I think the lectures are so good that there are hardly any direct questions can be asked. So everything is covered. So I think back to clinical scenarios, I think if I may ask a very sort of a basic question. What are the basic differences in management? You might think that I have not listened to the lecture at all, but I'm just to summarize it. Do you identify any major differences in managing a seminoma and a non-seminomatous, or what we call those teratomas? In what are the major management differences? Is it? I'm just asking very simple language. Is it worth knowing the difference? Whether it is a seminoma or teratoma? How does they differ?
Yes, in the this workout plan, so workout plans after this primary treatment will decide on this subsequent management, especially with this retroperitoneal recurrence. In that case, knowing about this, I will go first with this imaging modalities, this PET-CT. So whether there's any residual retroperitoneal mass, whether to go for a PET-CT or not, will decide based on this histological type. So in the usually it is not indicated in the non-seminomatous germ cell tumors, but in the seminoma, yes, it definitely, because there will be this tumor-related desmoplastic reaction. So that unnecessary imaging can be avoided by knowing the histology. And apart from that, the seminoma is more radiosensitive, but non-seminomatous germ cell tumors, they are less. So in that case, if there are any patient with this chemo, any contraindication for chemotherapy, the patient might benefit from this radiotherapy for the seminomas. And apart from that, there are no major differences for this surveillance and the chemotherapy regime and the duration.
Yeah. And what is the place of radiotherapy now in is what are the clear-cut indications for radiotherapy or retroperitoneal tumor masses in non-seminomatous tumors? Indications, clear indications.
Definitely, clear indication would be that if this retroperitoneal tumor, this may be a mature teratoma with having somatic differentiation. So those tumors usually chemoresistance. In that case, we can consider.
Right. So how will you know that is from the primary tumor, primary histological diagnosis? Isn't it? So okay. So is there any place for radiotherapy in teratomas? Teratoma means what I mean is non-seminomatous germ cell.
Again, they are radio resistant.
So there is no place.
Yes.
Yeah. Okay. So you mentioned about the retroperitoneal tumor masses. So suppose after the first round of chemotherapy, there's a residual tumor mass. You mentioned that what are the possibilities of that tumor mass, the histology of tumor mass?
So there is about 10% active cancer would be there, sir, and about 50% it could be a teratoma, and rest it might be a necrotic tissue.
Yes. So is there any way of knowing it? Because the management might change, isn't it?
Yes, sir. So
will the biopsy, I'm just asking, will the biopsy be helpful?
If can perform, yes, definitely, sir, it would helpful.
Yeah. So what will you go by actually? The retroperitoneal mass, more than the histology, it will be the size. To look at the size.
Yes.
So a small recurrence, then there is more chance that you might manage it more conservatively rather than going for lymph node dissection. And the tumor markers. So important is tumor markers. If you are residual mass with high tumor markers, then the higher chance that there will be active tumor running there. So you have to decide whether you go for a second round of treatment. Any other questions, Puni, comes to your mind?
Mahendra, are you there?
Yes, sir. Yes, sir.
Right. Can you tell me what are the indication for MRI, brain?
So if patient is presented with first instance, if there is any suspicious of brain metastasis, we can go ahead with brain MRI, sir.
Any other? One thing is neurological signs, yes. If the beta HCG is more than 5,000, again, it is a criteria for do the MRI. And alpha fetoprotein is more than 10,000.
Okay, sir.
And extended lung metastasis. And the non-pulmonary visceral metastasis also indicated. So those are the criteria for arranging MRI.
Okay, sir.
And few more things. So we are discuss about the orchidectomy. So young patient comes with testicular mass and you are planning to do the orchidectomy. So they are worried about their fertility. So in that case, they want to know about future plans for fertility and how sperm banking take place. Do you know about the sperm banking and what are the issues with sperm banking?
So we can take spermatogenesis from the biopsies and we can preserve, sir.
Why you want to do the biopsy and take the sperms?
Yes, we can take the sperm as well, yes.
So first you have to get the sample and assess the sperm's quality before starting banking.
Yes, sir.
Right? Otherwise, if you bank the sperms and after that, once thawed the sperms, the quality is not there, then problematic. So you are spending more money. So first thing is you have to assess the quality of the sperm of the patient. Then you have to inform the patient what is the process and what will happen to the quality of the sperm with the time. So maximum duration of sperm banking, what is the duration you can keep the sperms?
Can't remember, sir.
Usually maximum storage time is the 10 years. Okay. So you have to read about the sperm banking and the related thing. And other thing is, what do you know about the contralateral testicular biopsy?
So if after if we do the orchidectomy, if patient is in persistently elevated tumor markers, we can think sense multiple germ cell neoplasia in situ is there.
Okay.
We can suggest a testicular biopsy, a contralateral side.
So
And also
purpose
risk factors like cryptochrysum and as a risk factor, high risk patients also we can do testicular biopsy, contralateral.
Right. So high risk patient means sometimes the testicular volume is important, no? So if the volume is less than 12 milliliters, it is again recommended to go ahead. Right. Nishanta, do you have any questions?
No, nothing significant. Sometimes they might ask about the prosthesis as well, no?
Yes,
The
yes.
indications and when, the places.
And the
Because
complication of
exam
the
they would
prosthesis.
ask the more practical things rather than these more theories.
Yes, because I think all in all, what we all do is that the moment you do the orchidectomy, we just push them into oncology, and then most of it is 90% of time they manage it. And then all these regimes and follow-ups are done by them. We hardly ever see testicular tumors. I don't know your experience, Moni and Nishant, but you would have seen in our unit to find 2 testicular tumors in 1 year is magic. So I don't know. Maybe all the general surgeons are just taking the testicle out and sending them to Paranama. So because of
I have
that,
seen only one in Sri Lanka, but a lot of in Australia.
yeah, exactly. So Australia, I think the urologists are managing it, isn't it?
Yeah. Yes.
So here we just oncological management. So I think I mean, hardly ever they refer back for RLMP. This is lymph node dissection or any residual mass. I still don't know what they are doing with those. I mean, you have seen when you all are with us, they hardly ever they ask us to. I don't know whether oncosurgeons are doing it there, but I know what is your experience in doing retroperitoneal lymph node dissections.
I haven't encountered that.
Exactly.
Only
I
the
think if you
orchidectomies,
ask
yeah.
all urologists here, we don't
Yeah.
know what the oncologists are doing with the residual masses. So they may be going for second line chemotherapies and things like that. I hope that they are following these. I'll be happy if we had a radiology training, radiotherapy, or this oncology training as well, or in this discussion, because always this testicular tumor discussions, always is nice to have oncology person to ask what they are doing with the testicular tumors.
Anuruddha sir, what about your experience? Sir?
He's
So
sleeping. He'll go to sleep, I think. He will say that he's too old to, wake, keep sort of wake up to this point,
Yeah.
Is he there?
So
No.
then
Okay. Yeah, I think it's a big problem for urologists to have a very practical knowledge about testicular tumors. Rather unfortunate in this country, because mostly either general surgeons or some oncological surgeons or somebody does the radical orchidectomy and then send them to oncologists. And actually, most of the discussion which came out from this discussion, actually, most of the points are actually oncological management. One thing about the scrotal violation, the trainees have any idea about, suppose accidentally you think that you are opening up for a testicular trauma or infection, you open it up and you do a orchidectomy after seeing a mass or a necrotic mass, and then it comes as a tumor. What are the treatment or what are the management guidelines? Any idea? If you have violated scrotum accidentally?
So in that case, we have to complete this lymphatic removal with the exploration of the inguinal region, sir.
Yes, those days it was taken as, yes, any other comments? Scrotal violation, we call it.
What about the skin, the scrotal skin?
So we can take it because we have done the orchidectomy. We can consider as a curative surgery, but we can go for a radiotherapy because already we have violated the scrotal skin.
Yeah, I think we read about it. Those days it was taken as a urological crime, but now I think they have shown that this scrotal violation is they are not taking it very seriously, because you just follow the same guidelines as for any other testicular tumor, because these scrotal recurrences of scrotal seedling and those things are more theoretical rather than actually seen in practical world. So you don't have to actually have to keep them under surveillance for sure, but there is no additional treatment for the violated skin. Yeah.
Then why don't we go for testicular transscrotal biopsy, sir?
Transportal biopsy. I mean,
Yes.
yes, you are asking for trouble, no? So if you get 1 in a million chance, you get a recurrence, you have committed it. It's a error of commission. So this is of course accident. Transscrotal biopsy is still not advisable for any kind of thing. You just don't mention it at all at exam. But accidental scrotal violation, there are no specific guidelines nowadays to do for the skin incision or the skin violation. Nishant and Moni, do you have any other opinions about it?
No, sir.
Yeah. I think those days it was taken as a big issue, and then they used to give radiotherapy, and but now I think if you read around that, just you continue with the usual treatment, but you should not mention that you will do a transporter biopsy
Okay, sir.
because because the things are still open. The verdict is open, so should not mention that, right?
Okay, sir.
All right. Okay.
So any other questions?
I think everybody is
We
very
can
tired
conclude.
now.
Yeah, we can conclude the.
Yes, I think they were also very
Yeah.
comprehensive and very elaborated discussions and presentations. And this type of presentation, next time I think we should have it as question and answer. So straight away we must ask the question, and then the answer, maybe we can warn them, so they should give these details as an answer, isn't it?
Yes, sir. Yeah, that's better, I think.
Yeah.
Okay, thank you very much, all the presenters, and I highly appreciate the presence of Professor Neville Pereira. I think without him we can't think of these things. So thank you very much, sir. Again,
Thank you.
Yeah, we would conclude. Have a good night, sir.
Thank you.
And we should thanks for our the sponsors, Cipla Pharma, doing the given us this opportunity to continue the Uromet sessions. So other message is all the candidates who facing for exit exam. So you have to read more and more, and you have to do the MCQ as well. So we don't have much time to conduct the separate sessions for MCQ. So you have to do yourself MCQs and be ready with the these for the exam.
Yeah, whatever the MCQs we will be making will be going to the bank. It won't come to your. So we are enriching the bank. Okay.
Okay. Thank you very
Thank
much.
you. Thank you. Good night.
Thank you very
Good
much.
night.
Thanks.
Thank you, sir.
Good night, sir.
Nishant,
Thank you, sir.
Thank you. Good night.
Good night.